Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. Today we are talking all about IVF, answering some of your top IVF questions, and some advice about what to do when things aren't exactly going the way that you hope. Before we dive in, I just want to say a huge thank you for everybody listening, for all of your support and love. A couple months ago, we even got a feedback form on the podcast, and some of you spent so much time really giving detailed things you'd love to see, guests you'd love to have. And I just want you to know we've taken that all to heart, and you're about to see a change in the podcast happening soon and some other very exciting updates. So make sure that you stay tuned at nataliecrawfordmd.com/newsletter. You can sign up for the weekly newsletter. That's how you are going to get first access to all of the fun information that is coming out very, very soon. You are also going to hear some of your top fertility questions in this episode, and make sure that you know where to ask your questions. So you can ask them on Instagram at nataliecrawfordmd every single Monday. Some questions will be answered right there on Instagram. They will be answered in the weekly newsletter or here on the podcast. So make sure that you head over to Instagram, follow along, and ask your questions there. And a quick plug for the YouTube channel, because it has been rapidly growing as we have nice short form videos for you to be getting a gauge on maybe a single question that you have. So without further ado, we are going to jump in and talk about IVF.
Hi, Dr. Crawford. First of all, I want to say how much I love the podcast, especially the episodes about PCOS. As someone who has suffered with PCOS for 10 plus years, I found your podcast to be so insightful, and I really look forward to it every week. My question is about IVF. My husband and I have made the decision to go forward with IVF as part of our next steps in our fertility journey. However, due to some scheduling and traveling, we are thinking about doing our egg retrieval in July, so a few months down the line. And I was wondering what you would recommend for us to do between now and July in order to get us in the most optimal shape. Is there meal plans that we should be following, supplements we should be taking, in addition to, the testing that our clinic is recommending? Obviously, we are only hoping to do one egg retrieval and wanting to do what we can to make sure that we have the best outcomes possible. Thank you so much, and looking forward to hearing your answer. Bye.
All right. Well, there's nothing I love more than somebody who wants to be prepared. And I'm going to walk through a little bit about IVF really quickly and how I like to think about it, and then we'll answer this question about what to do to prepare. I want to start by saying that IVF often takes so much longer than you think it will, and clinics do it differently when it comes to different protocols. And this is an important piece, because if you say we want to do IVF in July, well, what does that mean? Are you looking to be taking the shots then, to do the egg retrieval, to be having an embryo transfer? Because the whole process for the vast majority of people takes much longer, and there's a lot of lead-in time and things to do to prepare. So if you saw me right this minute, it's May, for a consultation, you're probably realistically not doing IVF until July. So I think that you're on the right track by trying to make sure that you're getting all your ducks in a row. The way I want you to think about IVF is to think about what we're trying to do is get 1 month's group of eggs all to grow. So all your eggs, I always say, imagine they're born in a vault inside your ovary. Each month a group of these eggs comes out of the vault. From that group, one is chosen to ovulate, the rest die, and then the next month you have another group again. Well, each egg grows inside a small fluid-filled structure called a follicle, and in normal ovulation, the brain sends out just enough follicle-stimulating hormone to get one egg to grow. What we are trying to do is override this process and get all the eggs to grow. So this is usually a combination of suppressing the body and then stimulating the body. The truth is, some clinics do what we call a spontaneous start, where they just stimulate the body. There's no suppression. They try to lead in a naturally suppressed time, which is on your period. This can work for a lot of patients, especially high responders who might have a ton of eggs. But if you have a lower egg count or you are older, your body might have already started to try to identify that upcoming follicle. And so I don't love this approach. I love to use something to synchronize or prime, essentially to try to get the group of eggs all small and together. The bad analogy I use for this is to imagine this is a nest of baby birds. A normal ovulation is mommy bird bringing one worm in and the biggest bird gets the worm. If, however, I starve all the birds for a short amount of time, then they're all very hungry. There is no big bird. And now if I come and dump a bucket of worms in the nest every day, hopefully I'm at a position where all of the birds can grow together. That's kind of the idea here. So if I've already let your body start to develop a big bird, there's going to be somebody pushing their way and we might not achieve our full goal. There are times where a spontaneous or a random start makes sense. A lot of times I use this in a patient who's got a very high egg count and who has some contraindication to oral contraceptives. So maybe you've had a blood clot in the past or something that's going to make it so that we don't want to use those. That might be a circumstance where that's the best option that we have. Things that you can suppress with include birth control, progesterone, estrogen, testosterone, a medication called Lupron, even ovulation blockers. And these are all hormones or hormone blockers or modulators that work by essentially preventing the brain from sending out FSH. So the goal here is to get no big bird. Well, that suppression, if your clinic is recommending suppression, is going to be anywhere from 2 to 4 weeks. So right away, that's something that you have to do. And so one fault I see patients do is sometimes they say, oh, I want to do IVF in July. And in their brain, they're not thinking about anything and calling their clinic in July. Well, that is not a recipe to do IVF in July. You actually are going to need to start some of the suppression ahead of time if your goal is to be doing the shots and the egg retrieval. After the suppression, if you're using that, you'll come in for a baseline, which will be an ultrasound to evaluate, make sure that there is no big bird, essentially to make sure all the follicles are small and ready to grow. And then you'll start using your injectable hormones, and these are shots mostly of FSH. You will use them over the course of about 2 weeks total, so it takes about 2 weeks to grow the eggs. You'll be coming into the office during that time for monitoring visits, ultrasound, and blood work. And then what we'll do is do an egg retrieval procedure under anesthesia and take the eggs out of the body. From there, the eggs are fertilized in the lab, and embryos have to grow out to the implantation stage, which is a day 5 or 6 embryo. And this is where you could have an embryo transferred immediately, called a fresh transfer. Really not done as commonly because success rates tend to not be as good for the vast majority of people. The embryos can be frozen, allow you to have a bleed, and then synchronize and coordinate a frozen embryo transfer or an FET, or you can have the embryos biopsied for genetic testing. And this is called PGT, pre-implantation genetic testing. So how do you prepare for IVF? What should you do? So number 1 is going to be get all your testing done. Number 2, ask about your protocol. Know what the time, the lead-in is going to be. Often, the earlier you financially clear for a cycle, the earlier you can get a calendar. So even if you're not doing IVF at this exact minute, but you want to know what your schedule is going to look like, many clinics won't have the nurses spend the time in making calendars if you're not really committed to the cycle. So make sure you talk about finances, you know what it's going to cost at your clinic, is your insurance covered there or not, and make sure you know your expectations. I see very often patients come to see me from some other practice and they went through a cycle having no idea what to expect. How many follicles did we see? What is your AMH? How many eggs do we hope to get if everything goes perfectly? What does that mean as far as attrition in culture? Not every egg will fertilize, grow out to a blastocyst, be genetically normal, or implant and become a baby. Your clinic should be able to walk this math equation with you so that you understand, might you need more than one cycle? And a lot of this is odds and, of course, averages. And people do above and below average. But understanding where you start is going to be very important in this endeavor. Okay, but I think the root of your question was more, what can I be doing outside of talking to the clinic or doing my testing? And I think that it's really important to make sure that we focus on both egg and sperm quality. When I think about success, about IVF, obviously your age, your ovarian reserve are two components, but the quality of your eggs and your sperm and the environment of our body, all of this is tying back to inflammation, and that matters a lot. And it's hard to test. It's something you don't know till you go through the cycle, but you can see where sometimes the impact of having smoked cigarettes or used marijuana comes into play in what you're seeing in your outcome. So, number one, let's stop any bad habits that we have, specifically smoking cigarettes, any cannabis use. We want to make sure that if we drink alcohol, we are cutting it back. Alcohol is inflammatory. If you've ever drank and you've woken up the next day having a headache or feeling puffy, you get it. Your body's responding. So I'd prefer you not to drink at all during this process, but at least in the prep, be cutting it back so that you're getting your body to a place where it is not constantly being challenged, trying to heal from all this inflammation. We really want to focus on food. So from a diet standpoint, eating a lot of whole foods, of course, fruits and vegetables, they have a ton of fiber. Fiber is really essential when it comes to your gut health and decreasing inflammation, improving insulin resistance. Of course, fruits and vegetables have a lot of antioxidants. You want to be limiting things that we know are bad for us. Refined carbohydrates, added sugars, type 1 carcinogen meats that are highly processed. We want to be really making sure we're aware of what we're putting inside our body. A lot of chemicals. I've been a very outspoken advocate when it comes to environmental toxins. This is because more than a decade ago, I did research and fellowship looking at PFCs or perfluorinated chemicals and seeing how abundant they are. They're forever chemicals in our environment and how they impact our hormonal system. They are endocrine disrupting chemicals. And my husband came home one day when I was done doing research and I was cleaning out our entire kitchen. And he was like, Nat, we can't cook on one pot. And I was like, yes, we can. We can cook on one pot. We can get more later, but we can wash it. We don't need to have 200 pots. I want you to eliminate things that are potentially introducing toxins into your world. So off the very easy, this is in the kitchen. Ordering food, takeout food, because you don't control how it's cooked, but also the containers they're putting it in. When the food is warm, these chemicals are leaching into it. So if you can start eating more whole foods and cooking at home, you've already made a huge jump. But in your kitchen, Teflon, things that have nonstick cookware surfaces, any plastics, especially using plastics in a way that they get warm, whether it's warm food or in the microwave or in the dishwasher. Another thing I can call myself out on is that there's this mentality that bottled water is going to be a better option for you, but truly that's not always the case. And you have to deal with the plastics that can leach into the water. And maybe you don't keep it warm, but you know how that water got transported to the store, right? In the back of a truck. And I'm sure it sat out in places and got very warm. So bottled water, there are times where we need it. But there's other times where that's really not the best option for you. So a refillable water bottle that's not plastic, and really looking into your house into a water filtration system so that you can be filtering out any chemicals from your tap water. So remove chemicals from your environment, stop toxic behaviors, look at your diet for what you're doing. And then we're going to have some of the other kind of basic things, which is, to me, looking at your life and how can you decrease inflammation. Well, decreasing stress, this is something people will flippantly say it doesn't matter, but of course it does. The problem is that we're all wired a little bit differently, so what works for you may not work for me. But carving out time to reduce your stress, whether that's journaling, meditation, acupuncture, yoga, sitting outside with your feet in the grass, taking a walk, listening to the birds, we're all different. But carve out some time for you that doesn't involve your phone. Also think about using exercise as a form of decreasing inflammation and stress release. We also want to think about the fact that building muscle improves our body's hormonal system, how we process food, how we process energy, how we process sugar. So don't be a cardio bunny. This is a great time for more moderate activity, but strength training to build muscle and things like yoga, walking, Pilates, really trying to treat your body kindly. getting more sleep, set a good environment for this. And then when it comes to supplements, everybody's a little bit different. So I don't have just a magic poof supplement protocol. Prenatal vitamin needs to have at least 400 micrograms of folic acid. A vitamin D, I usually have my patients take a D3 at least 1,000 IUs a day. You want to be taking omega-3 fatty acids. Those are typically in prenatal vitamins, but if they're not, you're going to want to take a secondary pill. And CoQ10, I usually recommend a total of 600 milligrams a day if you're trying to go through IVF or you're having infertility. A male multivitamin for the sperm partner, and they can take CoQ10 200 milligrams a day as well for them. And then same rules apply when it comes to vitamin D, omega-3s, if those aren't in their multivitamin. Now, if there's certain things wrong, there might be different supplements or things that could benefit you. So PCOS, for example, I often recommend taking inositol. I often recommend that if you have endometriosis, we consider N-acetylcysteine. If you have very low ovarian reserve, sometimes we add in DHEA, but these are not everybody should take all of them because your hormonal environment is different. Not all supplements are created equal, so you want to make sure that you're using supplements that don't have a lot of additives, that they've been third-party verified, and that for the most part, I don't love multi-pills that have 100 different things in them besides a prenatal vitamin. It's better to take just a single ingredient supplement for many things. And then always talk to your doctor about supplements you're taking because there are things in certain supplements. Biotin is a great example where too much of it actually interferes with our process. It interferes with the sex hormone binding assay, meaning that I cannot trust your lab work anymore, which puts you at a huge disadvantage going through an IVF cycle if I can't rely on your blood work. So more is not more when it comes to supplements. In the perfect world, we would get all of our nutrients from our food. But the reality is we often don't live in a perfect world. And so to act like certain nutrients do not matter and that supplements are all bad, you guys know I was a nutrition major, so that's not an ideology that I believe in. I believe in there is benefit based on your exact diet and circumstance where supplementation of certain nutrients can be helpful. But more is not more, and always talk to your doctor. All right, moving on to another question about IVF.
Hi, Natalie. I recently discovered your podcast, and I've been binging on all of your content, so thank you so much for all of it. So I'm considering doing IVF a second time, but I got severe OHSS the first time. So my main question is how you think the protocol could be changed to avoid OHSS, but still be worth it. So a little context. I'm 37. I have PCOS and endometriomas. My first egg retrieval was when I was 35. I had 24 follicles mature. But because my estrogen was climbing, my doctor had me take the Lupron trigger. And so the blood work looked good, but halfway through the egg retrieval procedure, she realized I didn't respond to the Lupron trigger. So she stopped the procedure and had me trigger with HCG. And we were able to freeze 2 healthy embryos. But I developed severe OHSS in the following days, and the excessive fluid collapsed one of my lungs, and I was hospitalized for 6 nights. So since then, I've tried IUIs with letrozole, no luck. We'd ideally like to have 2 kids. And actually last week, I had 2 endometriomas removed, and my uterus and tubes looked clear. So I'm debating whether to move forward with the frozen embryos or to try IVF one more time to help increase our odds of being able to have 2 kids. So, yeah, I'm just curious, do you think it's safe to try IVF again? And if so, how would you recommend the protocol be different? All right, thank you so much for your time. Really hoping to get an answer. And, thanks for all you do. Really appreciate it.
I am so sorry for everything that you've been through. And this is such an unfortunate situation. It sounds like your doctor did everything possible to try to prevent this. But then congrats on 2 embryos, which is so much better than just having the cycle completely canceled. However, OHSS is a big thing, and a lot of times it is swept under the rug. And I think this brings us to a bigger discussion. So I have had patients who have both PCOS and a component of hypothalamic amenorrhea, which I suspect is what is underlying here. But let's step back and think about protocols really quickly, and then I will get to answering what I typically recommend in this situation. So when it comes to IVF, I have to override that normal processing system. We already talked about suppress and stimulate. One of the common medications that we use to also suppress and synchronize the eggs is Lupron. And Lupron is a medication that works at the brain. Officially, it works at the hypothalamus, and it's called a GnRH agonist. Well, if we walk back the science, GnRH is gonadotropin releasing hormone, and it works to tell the pituitary gland to send out FSH and LH. It's an agonist, which means it upregulates it. The pituitary gland only has so much FSH and LH in it. So when you first take Lupron, it is going to send out all the FSH and LH you have in your pituitary gland. But then if you keep taking it, there's nothing left to send out, and essentially now your FSH and LH levels are low. This is why Lupron can be used many different ways in a cycle. It can be used before the cycle begins as a suppressant because you start it when that FSH and LH do not matter, either because you're overlapping it with birth control or you're in the luteal phase of your cycle. It can be used as the beginning part of your stimulation, maximizing that quote unquote flare effect, saying, I'm going to have your brain send out everything it has, and then I'm going to start shots of FSH right after that. I don't love that protocol because I feel like your brain's never going to send out as much as I could give you in shots, but it's an option. And then it can actually be used as a trigger. Now, what does that mean? Typically, as an egg gets mature in a normal cycle, what is going to happen is that the brain is going to sense the high estrogen level and will send out a surge of LH. Remember that LH is luteinizing hormone. LH is released from the pituitary gland, and that results in that final maturation of the eggs, the completion of meiosis, and then eventually ovulation. And what we're trying to do with IVF is complete meiosis so these eggs can be fertilized, but come in at the exact perfect time before the follicles have released so that you have not had ovulation occur. So this is why with IVF, we're very specific on when you use the trigger and when we can come in and do the egg retrieval. Okay, well, we don't have LH isolated as an option for a medication. We have FSH isolated. We have the combination of FSH and LH together, which is called Menopur. It's so fascinating because we don't have a synthetic LH. The only way that we can actually have LH is to use Menopur, and Menopur comes from the urine of menopausal women that's purified. And because in menopause, when your ovaries no longer are working, ovarian failure, the brain really would love to see hormones made. So you have very high levels of FSH and LH coming from the brain to try to stimulate the ovaries. And so there's nothing for them to do. Those hormones get metabolized. They're in the urine. And so it can be processed from the urine. And we've got HCG. So the interesting thing about HCG, which is the pregnancy hormone, is that it binds to the same receptor as LH. If we remember why, remember that in natural conception, you have the corpus luteum, and the corpus luteum is after the follicle has ovulated, it reforms, and that corpus luteum is making progesterone. And the stimulus to make progesterone is LH pulses from the brain. However, the corpus luteum can only live for 2 weeks unless you get pregnant. If you get pregnant, that pregnancy is going to make HCG, and HCG is going to come in and it binds to the LH receptor, and now it can stimulate the corpus luteum to make progesterone. And as the pregnancy progresses, you'll have more progesterone stimulation occur. So HCG can actually bind to the LH receptor, and that's how they both help the corpus luteum make more progesterone. This means that when we do IVF, our options for triggering, for finalizing that meiosis, are either HCG or Lupron. Now the problem, or if we think about the basic difference here, HCG is going to work at the ovary. It's going to work. However, it lasts a lot longer in your body. If you've ever had a miscarriage, I've been there. I know it takes forever for HCG to get out of your body, even after the miscarriage is over. And all the time that HCG is there, it is stimulating the corpus luteum to make hormones. And these hormones include estrogen, and that will worsen ovarian hyperstimulation or put you at risk for it, just like getting pregnant will. So what we saw is that women specifically who had PCOS, who would go through IVF, would have a really hard time because we'd have to trigger them early to try to prevent OHSS. A lot of their eggs would be immature. If you would do a fresh embryo transfer, these women were getting really sick. And so a little over a decade ago, we really started shifting to freezing all embryos, even if you're not doing genetic testing, to help try to prevent OHSS. Because if you're not getting pregnant, there's no HCG, that's going to decrease the risk. We also started using Lupron triggers. Now, you can only use a Lupron trigger in a cycle that does not use Lupron. So if you use Lupron for a flare or for your suppression, then the pituitary gland is depleted and I can't use a Lupron trigger. So I can only use these in cycles with what we call an antagonist. In an antagonist cycle, there's no Lupron suppression. Your brain is going to sense as estrogen gets higher and want to send out an LH surge. And you're going to prevent that by coming in and using an ovulation blocker, essentially a medication that's going to not let the brain send that out. Those are medications often called ganirelix or cetrotide, called an antagonist, and they are very short-acting. If you take one late, you might ovulate, but they prevent the release. They don't prevent LH from being in the pituitary gland, but they prevent the release. And then if you come in and you take Lupron, it will override that and allow all of the LH out of the pituitary gland. So this is a Lupron trigger, and it has been revolutionary for patients who have PCOS or high egg count to try to decrease the rate of OHSS. And it's quite successful because it's very short acting. You don't have the same risk with the HCG. Obviously, these patients are getting freeze-all cycles anyway. The big kicker here is that your brain has to respond. So in hypothalamic amenorrhea, remember that part of the problem is that the hypothalamus and the pituitary gland are in disconnect. And because Lupron works at the hypothalamus to tell the pituitary gland what to do, if there's already a disconnect and the hypothalamus is shut off, if it's closed for business, not accepting customers, Lupron's not going to touch it. And so if you give a Lupron trigger to somebody who has hypothalamic amenorrhea, then what's going to happen is they're not going to have a response. And this is not common, but it definitely can happen. And it often gets confused with PCOS because a lot of times these patients may also have a really high AMH, they have no periods, or they've been on birth control for a really long time, so you may not know. And their diagnosis going into the cycle is PCOS, and we don't know that they have concomitant hypothalamic amenorrhea. So this can happen. This is how it can sometimes be presented. A lot of times patients will not get a rescue HCG trigger because of what you just went through. Ovarian hyperstimulation syndrome can be very bad. You can get very sick because when you have more eggs, you have more granulosa cells, which are the cells in the eggs that make estrogen. As more eggs are growing, you have higher estrogen levels. When you get ovarian hyperstimulation syndrome, it is because that high constant estrogen disrupts your whole body. Essentially, the way I like to think about it is it makes your blood vessels leaky, and the water component of your blood starts to leak out, getting all over your body. Your blood gets very thick, so it puts you at risk for kidney failure, blood clots. But your third spacing water, getting fluid on your abdomen, your lungs, it can get infected. You can have to have your lungs drained, your abdomen drained. You can get hospitalized like you did. So it is not something that we take lightly. So a lot of times, if you're at risk for this based on how high your estrogen was or how many eggs you have, you might not get an HCG trigger. And the cycle might just be canceled and you might just have to restart again. When I have a patient who has both, so I have a current patient who is gearing up to go through treatment. And what we usually do is try to essentially minimally stimulate them. You purposefully understimulate somebody knowing that they're going to have to get an HCG trigger. What this means is that usually we use a low dose of gonadotropin, so the FSH LH medication. And we monitor things very carefully because we know that the higher that estrogen gets, the more at risk you're going to be. Also, you can make sure that you're using a very low dose of HCG, not a ton of it, and you're going to want to post-treatment. So sometimes there are options for post-treatment, whether it is cabergoline, letrozole, or actually a GnRH antagonist, one of those ovulation blockers again, after the retrieval can actually help lower those estrogen levels a little bit faster. Other things are more on the doctor end as far as going into each follicle and making sure that we're really destroying as many cells as possible and watching the cycle really closely. If you're worried about this, you can always have some blood work checked ahead of the cycle to verify if your LH and FSH are super low. So if you got a diagnosis of PCOS, you're going into a cycle, a Lupron trigger is the gold standard. But if you have a history, if you're underweight specifically, if you've exercised a lot, been calorie restricting, had an eating disorder in the past, been on birth control pills for a really long time, you can always check FSH and LH before the cycle starts to verify that you have some in your body and that you're not in the position to not respond to a Lupron trigger, because I know that can be so heartbreaking. Okay, guys, this was some IVF Q&A, but I think it was a really great job of covering things to do before your cycle and some basics on protocols and trigger to give you a little bit of a standing on different options that exist out there. As always, I'm so thankful for you. So thank you for all your support as a podcast. As changes and updates are coming soon, I can't wait to share them all with you because all the content I make is truly just to help you guys. So please follow along on Instagram at nataliecrawfordmd, sign up for the newsletter at nataliecrawfordmd.com/newsletter, and go check out the YouTube channel. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.